Good afternoon, everyone.
Good afternoon.
Thank you all for coming. How exciting. It's so nice to have the room full, and I know some of you braved a bit of a snow squall. It's just letting us know that winter's on its way for sure. I'm pleased to welcome you to this month's What's Up Doc session. Once again, we want to acknowledge and thank Eastern Bank for their generous support of the What's Up Doc series. The Concord Hospital Trust staff developed this luncheon as a special benefit for our donors, as a way to express our ongoing gratitude for you, for your support, and as a way to provide you with like an insider look and a first-hand opportunity to learn about the amazing healthcare providers and the latest in treatments offered here at Concord Hospital. Our hope is that you will learn from, by attending What's Up Doc, you will be able to learn new things that the hospital offers and bring them back to your friends, your family, your community members, and help us promote the hospital that we love so much. I believe you will find today's presentation truly amazing. It is my pleasure to introduce our guest speaker, Dr. Aurel Mihai. Dr. Mihai is a hyperbaric and wound care physician at the Wound Healing Center at Concord Hospital. Dr. Mihai was drawn to hyperbarics and wound care by the need he saw for specialists who deal with difficult and disabling wounds, the satisfaction of returning patients to a normal life without the need for invasive surgery, as well as the opportunity, to work within a small niche of medicine that is truly the gateway to a world of cutting-edge techniques, tools, and science. Dr. Mihai is a graduate of the Ross University School of Medicine. He completed family medicine residency training at St. Joseph's Health in Syracuse, New York, and then he completed his fellowship in undersea and hyperbaric medicine at the State University of New York, Upstate Medical University. Please join me in welcoming Dr. Mihai.
Does everyone hear me coming through the speakers? Is that working? Great, okay. So thanks for the introduction, and thank you all for being here. I'm really overwhelmed at the turnout. So we'll get right on with it here. So this is about when wounds won't heal, what we do here for wound care, how we help, and then maybe a little bit more about that. Yeah, let's do. So a bit more to start. Who am I? What's the Wound Healing Center? What do we do? I'm a fairly recent addition to Concord Hospital. I just started here in August. Pros and cons to that, but we'll leave it at that. And I'm a graduate of Undersea and Hyperbaric Fellowship in Syracuse, New York. So what does that have to do with wound healing? How do they all combine, right? At our Wound Healing Center, we do wounds primarily, we treat that. But a lot of what we see in hyperbarics, on the clinical hyperbaric side, comes from wound care, right? So we'll have wounds that come to us because they're difficult to heal, they're not healing. And certain classes of wounds, certain types of wounds require more advanced wound care, more advanced tools than we can offer otherwise. So one of the things that we do is hyperbaric medicine for that. We'll talk more about that specifically. You can tell is a big part of my training, and that's a big part of what we do. Hyperbaric medicine, though, and I'll get a little bit into this as well, it goes beyond wound healing. A lot of the mechanisms behind it are similar to wound healing mechanisms, but because of that, you can extend it to other things. I'm being vague for now, purposely, but we'll get more into it as we go along. I don't want to give too much away right off the bat. And of course, undersea medicine is part of the name of the fellowship. What does that have to do with it? I'm not going to talk too much about that today. We can talk about it another day. Feel free to grab me afterwards or in clinic. But it is part of what we do, and it is related to hyperbarics. And hyperbaric clinical medicine did stem from undersea medicine, particularly growing out of some of the dive medical officers in the world wars, particularly World War II. There were a lot of people around doing that sort of thing, and hyperbaric medicine grew out of that. So, brief disclaimer, this is not medical advice, and please don't try anything I'm going to talk to you about here at home. It's all been done. People have tried to use dermal tools on their calluses and their wounds and cut off whatever is sticking out that shouldn't be. Please don't do it. Don't build your own hyperbaric chamber. None of that turns out well. So, wound healing, what we came here to talk about primarily. We're going to talk a little bit about normal wound healing and then delayed wound healing and what the difference is and why some wounds don't like to heal. And then there's standard wound care and advanced wound care. The line there is a little fuzzy, but you'll see that there's certainly things that are well beyond that line, and then a little bit beyond. So, wounds. We'll start with your typical wound. We'll say it's traumatic, we'll say it's not spontaneous, it doesn't just happen. You bumped into something, you scratched yourself, and now you have a hole in the skin, and the first thing that's going to happen, you're going to have red blood cells and platelets that rush to fill the gap. We call that bleeding, and hopefully the bleeding will stop because of the platelets and the blood cells that are stuck together. One of the first things that happens, you get this little fibrin clot there, and that is a temporary stopgap so that nothing else bad happens. Immediately after that, the arrows start on the right, it's a little confusing, but immediately after that, you start to get some neutrophils. These are some of your white blood cells. They come in. You'll notice some swelling. This is an inflammatory phase. It's normal. Things get a little red and swollen. Your body wants to get more blood there, more white blood cells, fight off infection, start some deposition of some other things that will help you, like collagen, to grow scars and stronger tissue when they come together. So this is early inflammation right off the bat and going for another day or so. Later inflammation, that's all normal too. All of this inflammation, we normally think of inflammation as a bad thing, but that's only if it's delayed, if it's chronic. In the acute phase, it's normal. And the late inflammatory phase, a day or so later, you start to get macrophages, a different type of white blood cell. They come in and they help to clean things up too. After that, you get proliferation. You get these fibroblasts, which look vaguely like peppers in this slide here. But they're the ones that are going to come in, and they're really the building tools. They're going to be putting down collagen. They're going to help dissolve some of the fibrin clot, that initial clot, and sort things out, basically. And the collagen, it's not going to be as strong as regular skin, but it does have other properties. It can cross-link better. It can contract over time, so that you'll see in all normal wounds, if you get a cut, you get a scar, the scar shrinks, it contracts, it's actually contracting. And over time, you'll get remodeling. That's part of where that contracting comes in. And the body keeps trying to get better and better at going back to normal skin, what it was before. It never quite gets there. You only get about 80–85% of your normal skin strength back. But normally that's good enough for everyday things. So where's the problem? The problem is this inflammatory phase, and this is why inflammation gets a bad reputation. So I want you to imagine that you have an area of skin that isn't getting quite as much circulation as it should for whatever reason. Either there's pressure there, we'll talk about all the reasons, but either there's some pressure there causing tension on the skin, or your arteries just aren't good enough to get enough blood there, or overall your health is otherwise rather poor and all the skin is just kind of barely hanging together, or there's something underlying, like an infection or something worse, okay, underneath, that's causing either the wound itself in the first place, the spontaneous breakdown, or the trauma isn't getting better. The wound stays there, you get this sore ulcer, maybe it gets worse over time. And that's really the problem, is your body's trying to fix it, but the sore is still there. One of the two has to win out over time. Either it will close or it will get worse. And this is where we come in. This is where we can help with that. delayed healing, when is enough enough? When is it too long? I draw attention to this because a lot of wounds will just heal up on their own. We talked about those phases where for the first couple of days you have some inflammation and then things close up nicely. And then for the next couple of weeks to months, you have scarring and remodeling and everything gets better. So basically, a couple of studies have shown that the average life of a wound is, even for a big wound, it should get halfway better within a month, roughly speaking. The actual studies say about 40%, but about half healed in 1 month is normal for a big wound. For a small wound, it should just go away. If it doesn't get halfway better in a month, then it's probably not going to heal up completely by 3 months. That's what these studies are saying. So basically, after 1 month of whatever it is that you're doing, or whatever it is that we're doing, if it's not getting better, we need to change that. So in the primary care setting, that might mean after a month of trying something else, or after a month of Band-Aids and whatever else you're doing, it's time to see a wound healing specialist where we can go a little bit beyond that, try something else. And the same goes for us too. If we're trying something and nothing is getting better, within a month, that, at least for me, but I think for everyone, is the point where you gotta start thinking, well, I gotta change something that I'm doing. Think about something new. Because if it hasn't gotten halfway better in this last month, it's not going to get better over time. So then we get into the main causes of the wound in the first place, and then the delayed healing, because essentially it's the same thing. If you fix the underlying problem, the wound will go away, and it shouldn't come back. So the first thing that I put up there is venous stasis, venous disease. So you can see this in varicose, tortuous veins that are large and bulging and sometimes blue, or even the little tiny veins. They all show that there's some venous disease there. You might have some pain and heaviness and swelling in the leg. The skin might turn red. This is the fluid that comes out of circulation, just leaks right through and deposits there. It's kind of like getting a tattoo over time of the leg with all the iron deposits there. And it turns red, and the skin gets a little irritated and hard over time, gets kind of leathery, and it can break down over time, or something will happen to it and you'll get a delayed wound. But that's one way in which this happens. Archyreal disease. So this was fairly straightforward. You just don't get blood there, and without blood, tissues break down. It's like any other tissue. So you might have bad pulses there. You might have pain when you use the muscles a lot. This is very similar to other sorts of pain that you get with bad blood flow. So for instance, angina. If you have pain in the chest when you walk a lot, or do any kind of heavy activity, it's the same sort of thing. The heart's not getting enough blood, so it hurts. In this case, the legs aren't getting enough blood, so they hurt. And this happens even without having any arterial problems. At some point, if we're overworking ourselves, we'll get cramps, it will hurt. This is the same problem, just chronic. Okay. After that, you get pain even when you're not doing anything because there's just not enough blood flow. And finally, the skin breaks down. Or this can be accelerated by trauma or something else. Okay. Then you have plain old pressure. If you put pressure on a certain spot for long enough, you'll break it down. The skin will break down. This is partly just from trauma, and this is also in part because that pressure, you'll notice if you press on your skin, it turns a little bit paler for a moment. The blood is going away. So in this case too, it's partially an arterial issue, but it's really more of a long-term just pressure and trauma on whatever site it is. And most often, this is combined with neuropathy, which is why I put it up there, wherein you can't feel the problem, so you sit or lay on whatever it is. But sometimes it's just a matter of being incapacitated, either temporarily or permanently, and then you can't move. Sometimes the two are combined in that sense too, in our patients who are quadriplegic or paraplegic, and they have both the neuropathy and the pressure in that sense, and that's more permanent. Sometimes it's just an ICU stay or a very long surgery, and we do try our best in those settings to move patients, to put all kinds of cushions and foam and things to protect from that kind of ulceration, but sometimes it's not possible for whatever reason. It might just be as simple as if a patient has 20 tubes going to every part of them. There's no way to move them without pulling one of those things out. And the priority is on helping the patient survive. And so 3-4 days later, when they're out of the woods, we'll deal with whatever happens. But sometimes whatever happens is a sacral ulcer, on your bottom, that it's very difficult to heal at that point because we're all sitting on our bottom. Well, you're all sitting on your bottom, so we sit on that part of our body a lot. And so you can imagine that even for somebody who's mobile, who doesn't have a lot of other problems, I've even seen patients who are otherwise fairly healthy who just can't get rid of it, because if you think about it, you're sitting or laying for so long during the day that it's very hard to get rid of these. It's hard to get rid of all of these, but this in particular. Okay. I'll go through this one case here as a special case, diabetes. And I've highlighted that it's arterial, it's pressure, it's neuropathy. Diabetics are somewhere on the spectrum of that. There are some diabetic wounds that are almost purely arterial, and there are some that are almost purely neuropathic with great blood flow. Most of them are somewhere in the middle. They can't feel them, so they step on a certain spot and they step in the same way all the time. And there's also bad blood flow. The blood flow is a problem, and primarily in diabetes, because you have these sticky red blood cells full of sugar, and they tend to stick to things, and they tend to break down the small blood vessels. Because of that, they clog them up, they break them down, and then the small blood vessels go away, and then the nerves that they're feeding go away, and then the skin that is being stepped on and being fed by those small blood vessels, that goes away too. So it's a very, very hard problem to deal with. It's a combination of things. Diabetes isn't technically one of the primary types of wounds, but it's a combination of others that's so common that it might as well be. And we do often consider it that for many purposes. And finally, there's other special cases. This one is, if I remember right from when I was looking up images for it, is a melanoma. So the skin cancer can show up as a chronic wound. And I was talking earlier about other things that make wounds not want to heal. So that could be infection either on the surface or deep underneath as a bone or a tissue somewhere, or a prosthesis or something like that, or it could be something like this. And so another one of those things to consider, either early on if it looks funny, or in this case it doesn't look funny, it looks like a normal wound. If it's not healing with normal standard wound care, then maybe you need to biopsy it. That's part of the algorithm as well. So, standard wound care. Step one, taking care of the whole patient. This is a team effort. It's not just us. It's primarily not us. It's primarily the primary care provider, but also all the other providers that are taking care of whatever chronic health issues the patient has. In particular, though, don't use nicotine, don't smoke. I specifically put nicotine up there, though, because that goes for chewing tobacco and vaping and all the other things that contain nicotine, including even some of the things we try to use to get off of other tobacco products like the gums and other puffers and things like that. The problem with nicotine specifically, I mean, the problem with smoking, there's many problems, but cancer is a bad problem, and lung disease is a bad problem, and all of those do affect wound healing. But nicotine specifically will squeeze your blood vessels shut, and as we've said, no blood flow means your wounds won't heal. So that needs to stop, and that's very, very hard. Other chronic conditions that I was getting at, especially diabetes, trying to get that under control. You probably won't get things like nerves growing back into those places where they receded from, but you can stop them from advancing further and putting you more at risk. So very important to stop that. There are other conditions, though, too, that it's important to just get them under control. There are chronic conditions that you can't fix them 100%, but you can try to help them. Things like lung disease, COPD. If you can't get oxygen in, that's almost as bad as not getting blood to where it needs to go. So if you have very, very bad lung disease, that needs to get taken under control. And even other things, heart failure, same idea there. If your heart's not pumping, you can't get blood there, et cetera, et cetera. You know, we can go on. Every wound care is our own special little piece of the pie that we try to become experts in, but it's a bigger, it's the whole patient that we have to look at, the whole person. We have to consider these things and ask our patients and ask our other providers, please take care of everything, don't just focus on this. And then of course, nutrition, something I try to talk to everybody about. I didn't put in there also, but also sleep is important. Sleep is when you regenerate a lot of tissues. But nutrition, protein is very important. That's how you're going to build back a lot of the tissues that you need. Vitamins. There's not a ton of research on every vitamin specifically, but some of them there's more research than others. So vitamin C, for example, has been well known for a very long time. You might be able to think of what the deficiency of vitamin C is called. It's been around for hundreds of years. Scurvy, right, exactly. So, and that's a real thing. If you don't have enough, you'll have old scars breaking down everywhere. You'll have bleeding gums, you'll have things like that, and that's a clear thing, clear indication. And zinc is also important. It's not one of the vitamins, but it's very important. And mega doses of vitamins aren't necessarily important, but just having a right amount. So normally, again, not medical advice, but normally just having a 1-a-day type vitamin is enough to get most people to where they need to be. But if there's still a problem, then it needs to be looked into further and figure out why. Is there a malabsorption issue? Again, it goes back to taking care of the whole patient. Step 2, so now we've taken care of the big overarching problems. Now we're going to take care of the specific area. I'm saying a limb here, but it's not necessarily always a limb. It could be anywhere. Okay. So do the arteries work? We need to make sure of that. Now, part of that is checking pulses, and we won't check them every single time, but we'll check them now and again, and certainly the first time. They're not always perfectly reliable, though. Some people just have very rigid arteries, but they're very, very tiny on the inside. So you might feel a great pulse, but there's no fluid going through. You can get these arterial brachial, or ankle brachial indices, sorry. And that gives you a better idea too. There's other things that you can do as well, ranging from ultrasounds, which can give you the shape of the pulse. Certainly if you have very bad small lumen arteries and you try to get the shape of the pulse in there, you won't get the typical notches that you want. You'll just basically get a little flat sine wave at best. And then there's more invasive things. You can shoot dye in there and take a CT or an MRI. And that's why sometimes we need these, because we might have a specific spot that we're looking at. Yeah?
I assume that exercise is a very beneficial thing when it comes to arteries.
Exercise is beneficial, yes. That's a good point. And just to restate, you were asking if exercise is a good thing for arteries. It definitely is. And it definitely is in general also for veins. And I'll skip ahead to that part just to mention that, especially the calf muscles, and I'm not saying that's the only muscle you should exercise, but the calves almost act like a second heart as far as pumping venous blood back up to your real heart. If you aren't using them, say you're immobilized for some reason, then it's that much harder for the fluid to get back up, and that's one of the causes of the venous stasis. That, and of course, veins, like everything else, just kind of break down over time. You have these little one-way valves that are supposed to keep blood going in the right direction, but if they go backwards, if they backflow, then the only thing you got left is that pump. So yes, keep using the legs. The trick to it is that if you're going to exercise, you have to be careful to balance that out with the time you spend standing. This gets more intricate. It gets you can follow this very deep into the weeds as far as if you're standing still for a very long time doing your exercises, that will allow fluid to pool down into your legs. So that's a problem. So there's more to it. But yes, as a generalized statement, I totally agree with that. And so we were just talking about the vein veins. If you click forward, these veins work, and we can certainly do venous studies, Doppler studies, to check to see if there's that backflow, to see if the valves are working, and we can tell by general tone of the muscles, and we can tell by just physical exam and seeing how much swelling is there, and not just overall swelling, but swelling in the skin itself, edema, what we say, and then also this sort of tattooing of the very typical gaiter area, where you would wear gaiters. That's why I put that picture up there. It's a very very typical area where you get redness from this. And it's chronic, and it's usually the same on both sides, unless there's been some reason for it not to be the same. It could be trauma, could be surgery, sometimes it's uneven, but usually it's even on both sides. Okay. This gets a little bit more difficult. So does the microvasculature work? The capillaries, these get broken down particularly in diabetics and also in heavy smokers or other nicotine users. It's those tiny little blood vessels that when you check the rest of the vessels, they'll look fine, but then you'll wonder why do these wounds not go away? It's because the microvasculature is bad. We have fewer options as far as how we can check those. We can get individual indices, so we can check the blood flow right in a toe. Usually that's easiest in the big toe. We can also use what's called transcutaneous oxygen measurement to get an idea, where we put these little probes right around the wound to check for oxygenation in those spots. Unfortunately, the oxygenation is around the wound, not in the wound. So it's an estimate, but it's the best we've got, and you can usually take a bit of an average and figure out if this warrants further workup or not. Or basically, is this the problem or not? Okay. Bioburden is what we generally call all of the bacteria in the wound. We're all colonized by bacteria. It's just the milieu that we live in. We all have it on our skin. It's very typical bacteria for most of us, as in pretty much the same bacteria for most of us. But that assumes intact skin, normal health otherwise, and certain things will change that bioburden, as well as, or rather including having an open wound. So when you have an open wound, that the skin there is no longer protecting you against that bacteria. You have an area where the pH is different, where there's more nutrients for the bacteria, so it allows it to grow. So you have a spectrum between normal colonization of a wound, as it would be with the skin around it, versus infection. When it's infected, it needs antibiotics, it needs further intervention beyond just local care. But when it's still in that middle stage, we can do things. We can put certain dressings on there, we can debride it, we can do other things to assess and reduce bioburden. Reducing pressure on a wound is not just limited to pressure ulcers, it goes for any wounds. There are certain wounds, I've seen this particularly in post-surgical wounds that are just in very unfortunate places, right across where people normally wear straps for undergarments, where they just won't go away. And they're very frustrating. But if you can convince your patient in that case to stop wearing that particular undergarment for some period of time and just wear loose-fitting clothing, they will just disappear. And it's amazing. And it's just that one thing. But this goes for all wounds. This generally is a diabetic foot ulcer type situation. But even other venous stasis ulcers, we will use compression to try to help those muscles in the legs to pump fluid up. But the compression is such that it's very uniform, circular around the leg, rather than pinpoint. It's that pinpoint pressure. It's like having a rock or a marble stuck up against the skin that will create a pressure ulcer. So offload the wound. Okay. And then fixing the specific cause. Easier said than done, but arterial ulcers, they need blood flow. We can do that on the large macro level with a graft, a bypass, or even just an endarterectomy, going through it and cleaning it out. Okay. Venous ulcers, like I said, we compress those. We try to aid the muscles in their work, because we can't really aid the valves in their work. Those are gone. And pressure ulcers, neuropathic ulcers, specifically need offloading, but they may need all the rest. And usually it's not as clear-cut as one or the other. Sometimes it is, but many times it's more than one thing. Okay. I put this slide in here because, well, yeah, wound dressings are like salad dressings, right? It's the thing you put on top of the wound, the thing you put on top of the salad. And I was trying to figure out where in this whole talk to talk about dressings, because initially there was no dressing slide, and I feel like I would be remiss going through an entire lecture on wound care and not talking about dressing. The problem is that it just kind of becomes a natural part of here's your wound. You know, we go from top down of taking care of the patient, taking care of the underlying issue, taking care of all the local stuff, and the wound care just becomes part of the local stuff. So and the other part of it, the other problem is there's many thousands of wound dressing products in existence. There's more new ones every day, old ones fall off, out of favor, off the market, and keeping up with every single one of them is impossible, even for those of us that work with them every day. It wouldn't even be feasible to try to stock all of these. What we're trying to do is really figure out what do you want to accomplish, and we just talked about all that. So there's a couple of main things that dressings are supposed to do specifically, right? They're a part of the wound care plan. They primarily protect the wound from further damage and maintain a moist environment. Those are the number one and number two things in no particular order that these dressings need to do. All dressings need to do that. Just a barrier, even a Band-Aid just needs to cover the wound, protect it, maintain that moist environment. That moist environment is very important. There were studies done, the first groundbreaking studies back in the 1950s. It was Dr. De Winter who did these on pigs, where they basically just made some cuts in pigs for animal studies, and some of them were moistened and covered, and others were left open to air, as is the old myth of how should we treat wounds, leave them open to air, let them dry out. And what they found was that the wounds that were dry took longer to heal, they scarred more, they got more infected, they were more painful. And yeah, back in the day, that was the treatment, leave them open to air. And somehow that's just made its way down through the years as the way we should treat wounds. But the fact is, and that study's been repeated over and over again, and clinically it's been repeated every single day, you want to have a moist environment. I'm not saying wet, soaks are also not good, and I won't get into that, but that's also not good. But the basic idea there is you don't want it so wet that it breaks down the skin around it. But you don't want it so dry that the wound itself can't get nutrients to it, can't get skin growing into it, has a better environment for bacteria to grow in, those sorts of things. So maintain a moist environment. The other things there, all dressings more or less control bioburden, even by just protecting so that more things don't get in there. So that's a kind of by default, they will do that. But some dressings are specifically meant to control bioburden. We'll go into that a little bit. And again, some dressings are specifically meant to provide a little something extra to the wound. Most aren't, though. That might come as a bit of a shocker. A lot of the things that we do in the wound care center are just there to promote your own body healing itself. They don't add a lot to it until we come to the point that we realize the body itself isn't going to do it. So then we have to talk about things we'll talk about here: collagen dressings, skin substitutes, etc. Okay. And the final thing to say about dressings in this point here is that, you know, I mentioned dressings as a solid barrier that goes over them, but that really does go for anything that you put on it. So if you go and you slap that triple antibiotic ointment on there, which I'm not saying is what you should do. In fact, most of the time you don't need it. But if you put that on there, that's a dressing. If we put Vaseline on it, that's a dressing. Anything that you put on the wound is a dressing. So just FYI, little nuggets there of information. Does it work? Well, there was a recent study, I believe, from 2017 from Aurel and Fife, retrospective study of a whole lot of their clinical data showing that in 3 months, real-world results, 30% of diabetic foot ulcers are healing, 30% of pressure ulcers are healing, 40% of venous stasis ulcers are healing. And arterial ulcers, pure arterial ulcers, are so hard to identify they're not even included. That seems pretty bad, right? That's less than half of each. The truth is these are very difficult wounds to heal. And we just talked about all the simple things you have to do to heal them. But knowing what you have to do and actually physically doing it, staying off of your foot, staying off of your bottom, staying off of your back, keeping compression stockings on or compression garments on, keeping a certain part of your body elevated for hours at a time. I think most of us would find that it's almost worse than the wound. It's very difficult to do. And that's really what it comes down to, is navigating that fine path of, okay, here's what you can do, here's what we can do, where can we meet in the middle and heal this wound? That's part of what we try to do. This study, by the way, was done in response to many other published facts and figures out there that were claiming, oh, our clinic can heal 97% of wounds in 3 months. No, no, you can't. And I don't think that any clinic out there is far from these numbers. It takes more than 3 months sometimes. I think if we were to follow this out to 6 months, a year, 3 years, whatever, you'd see higher results, but it takes a while. Okay? So that's the basic wound care portion of this. I'm going to talk a little bit about some of these advanced wound care modalities that we have. Silver in itself is antimicrobial in certain minute quantities. There's a lot of dressings out there that have silver in them. So what we can do is, in order to control the bioburden, we can use one of these. I mentioned that there's a gray zone between basic and advanced wound care. We'll very often start right off with one of these if the wound looks like it needs it. We won't have to wait for it to wait a few weeks, see how bad it gets, etc. So this is one of those gray zones. It's advanced wound care because it's not a plain dressing, but it's not super advanced. Same thing with collagen. We go to this pretty quickly. I personally like to use it especially for deep wounds where I know this wound needs to come up before it'll get close. That's generally skin doesn't like to go down to deep valleys and come back up, and even if it did, you don't necessarily want that, because then you'll either have it grow over and form an abscess inside, or you will have a big divot there. You don't want either one of those. They both cause problems. So collagen is a way that a fairly basic advanced wound care product that you can use. It comes in many forms. Some of it's just crushed up powdered collagen. This is one of the other products that we have in our clinic that we regularly stock and use. As far as we can just put these down into a deep wound, and the body will take up some of that collagen and add it to the collagen it's already making. This is great. At least that's the theory. It's hard to prove this. It's easy to prove in the lab. It's hard to prove it in a patient. But that's the theory. And it seems to work more often than not. Okay. Another thing that we have, this is just one version of ultrasound, low frequency ultrasound therapy. So some wounds are very painful. Many wounds, may or may not be surprised to know, are not particularly painful. The nerves are done, so there's no pain there. But some wounds are, and it's hard to mechanically debride them and remove that outer layer of bad stuff there. We call it slough collectively, but it includes extra bacteria that shouldn't be there, dead skin cells that are either floating in or just growing there, other necrotic tissue that has died during the course of things, been sloughed off there, white blood cells, red blood cells, all the other stuff. It all comes together, it's called slough. And we need to remove some of that because it's a haven for more bacteria to grow. It changes the pH of the wound, makes it harder to heal. It physically prevents skin from growing in that spot. So when we can't do that physically, surgically, we can, sharply, we can do that with low frequency ultrasound, and that will help to break it up and kind of slough it off. We can do a few other things. We can do it enzymatically as well. We can put a dressing on there that will help to remove it. None of these methods are quite as good as the sharp debridement, which is why we prefer that, and we'll go into it, not just because we don't like to be mean, we don't like to cause pain, but it is much more effective at helping the wound heal faster. So we'll go that route most of the time. Sometimes we can use this as well. Negative pressure is great for many wounds, especially deep gaping wounds that we know are not going to heal anytime soon without this. It's very often used first line in surgical wounds, and in fact that's where this came from, was post-surgical, where you have a wound that for some reason or another you do not want to close it back up. Either it's a traumatic wound, a lot of the tissue's been damaged, was removed, and now you can't close it back up, or it was infected, or there's potential for infection, like a large bite wound or something like that, where for some reason you don't want to bring it together. So what you're going to do, you're going to leave it open, you're going to put one of these in there, and it's basically just a big piece of foam that's sealed with a vacuum pump. And what that will do, it will stimulate the wound bed to grow, As you can imagine, if you've ever had a suction cup attached to you, you'll see that it brings blood to the surface. Same thing here, it'll bring blood right up into the tissues, which is great. It'll mechanically stimulate it a little bit, which is great. It'll actually suck up all that bioburden that we don't want there, all the good things. These things work pretty well. If you can get a good seal, some places are harder than others, if the wound is the right size and shape. Not always perfect, but it's a good modality when we can use it. Skin substitutes, I mentioned briefly. I put a couple of the ones that we have up here in our clinic that we normally use. Some of them are, in general, not these specifically, I won't go through these specifically, but in general they can be donated tissue, they can be placental tissue, they can be neonatal foreskin tissue, they can be cadaver tissue, they can be animal tissue that's been discarded. And what is generally done with these tissues, it's one kind of tissue. It's not that they're all mixed together, but you take one specific kind of tissue, you'll homogenize them all together, all the donated tissue. So you're not getting a transplant, you're not getting somebody else's tissue. But they're all homogenized together, they're all spun together. Anything that's going to cause a reaction is tried to be removed and taken out. Because when you get a transplant, that's one of the issues, is rejection. So we try not to have that as a problem. And then they're grown out in petri dishes. They're clean, they're make sure there's no flea disease and all that. And then they're grown out in petri dishes, as you see there, or onto glass slides. And we get them, we apply them. Now, anything that's left over that has any markers on it that's from another person will get rejected. So most of this, it's just a fancy dressing. It does get rejected. But what does kind of seep out of it is the growth factors, some of the collagen, some of those other factors that the body itself is producing, but if we've gone this far, the body is not producing enough of them, so it needs a little bit of a boost. And again, there's only certain wounds where it works. Okay, and finally, the thing I did for your fellowship in hyperbaric oxygen therapy, which has a lot of other uses. I'll talk about more in a second, so I won't belabor the point now. So this is what we have available to us as advanced wound care products, ranging more or less from common things we use all the time to very specialized things. And what I will say though is not every wound needs the kitchen sink, and it's not just that we're trying to belabor the point. We don't want wounds to last longer, but there are certain things that will actually harm one patient if they're used incorrectly. So negative pressure. Great example of that. If you use it on the wrong patient, it can cause more harm than good. Certainly, hyperbaric oxygen is a fairly benign treatment for the most part, but it can be hard on life because you're there every day for an extended period of time getting these treatments. And if you don't need it, we don't want to put you through that. Skin substitutes, if you use it on the wrong wound, can cause infection, and other things like that. So there's good reasons to be very selective about what you do, not to try it on your own, and certainly reasons, try to keep up with the research and the data on our end with what's good to use when, and what other specialists might not know. So that's it for really the wound care as a whole. I have a little bit of time. I'm going to try to speed through a little bit about hyperbaric oxygen therapy itself, how it works, why it works, and then I'll even go on a limb a little bit and talk about other cool things that we might be able to do in the near future with it. So the effects of hyperbaric oxygen therapy, in a nutshell, in a single slide. Primarily, you increase the oxygen in the wound and you increase the pressure. Well, in the whole body, really. So those two things are both good in themselves in certain cases. The oxygen primarily, I think you can understand why that's good for wounds. You need oxygen delivered to tissues. The oxygen and the pressure can also act as triggers, though, for the body to do other things. So there's an antimicrobial effect to high-dose oxygen therapy. When you get up above a certain value, a certain pressure, you actually find that it starts to kill off certain bacteria. So that's important. You'll actually find that there's those white blood cells we talked about way back on the first couple of slides. They need oxygen to make the products that they use to kill off bacteria. So if you have a wound without oxygen in it, you need to get oxygen there somehow. If you don't have enough arteries to get to it, the next best thing is to put you in a chamber that will give you so much oxygen that it will diffuse through your tissues, and that's basically what it's doing. So the antimicrobial effect is pretty huge. Ischemia reperfusion injury is a thing that is a hot topic of research, has great potential to do a lot of good, and that's the last thing I'll end on. But for now, suffice it to say that a lot of injuries, a lot of wounds, and maybe more outside of wounds that we help with is due to this phenomenon where blood flow stops in a certain area, and that's called ischemia, and then it returns. But because that tissue has had poor blood flow for a period of time, it started to degrade. And now you get new blood flow into it, and you have a whole lot of problems from that. You have, well, I'll talk about what you have in a minute. I don't want to get ahead of myself. Reducing swelling. So one of the effects of oxygen is it constricts blood vessels. And I know I talked about nicotine constricting blood vessels and how bad that is. So why do we actually want that? There's some cases where we do want that. For one thing, despite the fact that you've reduced the caliber of your blood vessels while you're in hyperbarics, which is a shorter period of time than you would reduce them with nicotine, you're actually getting more oxygen to tissues, both because the serum is concentrated with oxygen and because you're getting it through your tissues by refusion. So overall, you're still getting more oxygen, but you're getting less of that fluid. And the fluid itself can cause pressure and problems in the tissue, especially things like crush injuries. That's a large one, but even going back to the ischemia reperfusion injury, one of the problems is the blood vessels are broken down, and now when blood rushes back into it, it just goes everywhere. And this will help to reduce some of that by just shrinking down the blood vessels. Angiogenesis is a very interesting thing that I will go into a little bit here. So wounds need blood vessels, and obviously where you've cut yourself, hurt yourself, there are none, okay? And when you don't have enough of everything we talked about, including oxygen, in the wound to fix that, it won't heal up. One of the things I highlight here, this is an old study by Robert Marks. It's done on irradiated jaws. And one of the things they did was they took biopsies of these jaws before and after hyperbarics, and they showed not only is the core of that wound, that radiation damaged tissue, too poor in oxygen to actually heal up. You need, depending on whose study you look at, between 20 and 40 millimeters of mercury of oxygen. The middle there is 5. That's not enough to heal. You need that value to heal a wound. Okay? The gradient itself is also so shallow that the body doesn't even know there's a wound there. So at this point, it's stuck in an inflammatory phase, but it's not really getting a ton of new nutrients. And they were able to show that there's not really a ton of activity going on there. If you put them in a hyperbaric chamber, not only will you increase the oxygen concentration in the middle to above the threshold, which is great in itself, but that gradient has gone from a gradient of 50 millimeters of mercury to a gradient of 300 millimeters of mercury, in this one example. And that's enough to trigger the body to switch on its fight or flight mode. It becomes an acute wound. The body recognizes that this is a wound, it's time to start the whole wound process over again. Send out those neutrophils, send out those macrophages. Let's start growing new blood vessels. So you actually get new blood vessels. And that's very important. What you find is during therapy, between treatments, early on, you still have some hypoxia, some low oxygen in your tissues there. But overall, it's getting better. If you see the gradient's getting a little sharper, a little better. And then by the time you're all done, you have new blood vessels and you have pretty good tissue oxygen throughout. So this is what hyperbaric oxygen can do on a microscopic level. There is proof out there. So there's a lot of indications that all act like wounds and all benefit from these things that we talked about. New blood vessels, reduction in bacteria and all that stuff. So we have these severe diabetic wounds that we know benefit from them. Many studies have shown that. We have infections in the bones. Here I put up an x-ray of someone's foot, and I put a circle around it, but I think even without that you can clearly tell you have 4 very nice bones, and then you have one that just disintegrates, and that's bacteria eating away at the bone. It's not always that clear, but when it is, you know that you have an infection in the bone. There's a problem there. By refractory, I mean you've tried everything else that you normally would. So IV antibiotics, get rid of that dead tissue. In all these cases, you want to get rid of that dead tissue. I don't really have enough time to go into all the details of it, but a lot of these, so for osteomyelitis, for radionecrosis, osteoradionecrosis, the radionecrosis type indications, that's where you've had radiation somewhere, very commonly the head and neck, or the bowels, or the pelvis, and now you have some tissue damage there. Either blood in the urine, blood in the stool, wounds that go to the outside, pain, scarring, problems in the jaw with fractures that just spontaneously happen, pain, open wounds, things like that. In all those cases are caused by radiation. They don't go away on their own. It's very similar to all the other wounds where the small blood vessels have been destroyed by radiation, and as we've shown, you can build new blood vessels. Those slides I showed you were actually from jaw osteoradionecrosis studies. And of course, flaps and grafts. So when you have a wound that's been surgically closed by rotating another piece of tissue into place over it, sometimes those new flaps will fail, and hyperbaric oxygen can help to keep them alive. Okay. So, last couple of minutes, ischemia reperfusion injury. It happens in so many different things. Ischemia is a loss of blood supply, reperfusion, return of that blood. This is a good thing. We want blood to return. We want to, otherwise the tissue would just die. But sometimes when it returns in the wrong way, or the tissue's just been deoxygenated for too long, it's too late, and there's going to be some damage just from the fluid coming back. You get damage from, among other things, swelling, white blood cells that attack this damaged tissue thinking that it's bad because it's damaged, and it doesn't look right. And these things called reactive oxygen species, which are basically oxygen radicals. They're oxygen molecules that are very highly reactive. They just bounce into everything and damage it. Okay. So there's already some ischemia reperfusion injuries for which hyperbaric oxygen is already being used. Okay. Gas embolism, this is where you have gas in your bloodstream for some reason. It could be either that you had barotrauma, so trauma somewhere from pressure, maybe in the lungs, perhaps often from scuba diving, but other things like that. And then because you have this break in the blood vessels in a very highly vascular place, like the lungs, you have air that gets into the bloodstream, and that can make its way up to the brain, for example. And that can cause stroke-like symptoms. And what happens often is that within a few minutes, that air just passes right through, that gas passes through, and the embolism's gone, but the damage has been done. It's an ischemia reperfusion injury. And hyperbarics, if you get it in time, can fix that entirely, if you get it in time. Decompression sickness almost exclusively with divers, but also with a few other very specialized things that happens. The bends, if you've heard of that term possibly. It's the same idea. You have little microscopic bubbles. They come up into your tissues. They go away, but by the time you see them, if you can catch them early enough, it's this ischemia reperfusion injury that's the problem there. Carbon monoxide poisoning is a very similar mechanism of action, and also the grafts and flaps. Even if you fix them, if you get perfusion going back to them, you have some damage there from that. So because, the trick is because there's no other good treatment for these indications, well, hyperbarics is it, so you're stuck with this. And we will do our best for you in these cases. The trick is that there are a few other very important ischemia reperfusion injuries, like heart attacks, like strokes. We know these are ischemic reperfusion injuries because what happens is an area, well, at least when it's ischemic, you have the other kind where you have hemorrhagic, where something pops. But more often than not, the vast majority of these are ischemic, which means blood gets blocked off. Usually it's a clot. So you come to the hospital, they bring the blood back, but it's already been an hour, 2 hours, a couple hours. So you're going to have that reperfusion injury. Question is, if you had hyperbarics right then, would it improve outcomes? Nobody knows. This is an area for more research. You have to be very selective about who you treat. Certainly the vast majority of people do fantastic just with that. But having talked to, this is going out on a limb now at the very end here, but having talked to some cardiologists, yes, there are those patients that they know based on what they see, either during when they reperfuse them, the length of time it's taken, the complications, or even findings on EKGs afterwards, they know there's going to be some more damage there. They know there's ischemia reperfusion injury there. But it's not common practice to go into hyperbarics after that. We don't really know what would happen. Theory states, based on everything else we know, it should work out well. But we don't know that for certain, and we don't want to harm anyone. And experiments take a long time to do. They're very complicated, very difficult to do. It's hard to do at a center like ours that isn't mainly built for this. But hopefully, slowly, this research data will build up, and we'll be able to do even more with hyperbarics, with the things we know work. And just to highlight that, these two indications alone are responsible for over 800,000 deaths yearly based on CDC data from this last year, from 2019. So it's a big deal. I'm not sure if maybe 1% of those people would benefit from hyperbarics, but I think that's worth it. But because there's other bigger research topics, it will take a while before we can do this. So I guess that's where we get down to the very end of it is, thank you again for being here. Because it's by being here, let me just say, by being here, that you now know about this, and you can at least think about it and continue the discussion and continue being interested, continue looking these things up. I'm always happy when patients can say to me, I've read about this, I've looked this up. I'd like you to get your information from reputable sources. I think I'm a reputable source, I try to be, but even reputable journals and things like that. But certainly anywhere you get it, at least it shows interest and it shows engagement, and that's fantastic. I think that's more than half the battle in most of medicine, not even wound care. But keep doing that, keep staying informed, and I know there's so much in the world right now that we have to be aware of. It's like everywhere you go, somebody's pinging you for your attention, and where do you divide it? But do what you can, and if this is something that's interesting, keep that up. So again, thanks for being here, thanks for listening, and if you have questions, I don't know if we have time, but I'm happy to answer them.
We have time if you have time.
Go ahead.
With all the different treatments that you described, from the different bandages all the way to the hyperbaric bands, does the general insurance cover that? Any of it? All of it?
Yes, some of it.
Okay.
So there's the indication, so our guiding society, hyperbaricists and hyperbaricists primarily, there's other wound care societies, but for hyperbarics, there's Undersea Hyperbaric Medical Society. They're the group that accredits the fellowship I went to, that gives us guidelines. This is the place where we meet and we discuss, what's the research for this, what's the research for that. And there is a set of guidelines, I believe there's about 14 indications total, that these are the things we know for certain, beyond reasonable doubt, we should be treating. Then that goes to insurance companies, and they will approve a subset of that. So they don't believe all of our research, and that's what it comes down to. But that's part of the discussion that we have to have. If I certainly don't like to turn away someone that needs hyperbarics, and there's ways that we can get it done and paid for if we truly believe that this is necessary, and we have done that in the past. So take each on a case-by-case basis. But certainly some of these things, diabetic foot ulcers, if we can prove it, that's the one that comes to mind primarily. But there's a couple of other indications that are fairly clear-cut, and if you can meet the right indications for it, you'll get it covered. It's all good. Yeah.
Is there any research on hyperbaric chambers used for people with lung disease, COPD, asthma, the extra oxygen periodically?
That's a very interesting point. A great question. Because you would think that it would be helpful. I'm not aware of any off the top of my head. And what I can imagine the problem being is that as far as we know, you don't get any long-lasting effects in the lungs from this intermittent oxygen exposure. This is why you want that, if you have COPD and other advanced lung disease, you end up with supplemental oxygen down the line.
Yes.
Because you need it all the time. If you have it intermittently, it'll help your body intermittently. And there's a few things that are longer lasting to some degree. And there is some research on a few related things, I want to say, but it's very, very, very small right now. There's certain things on chronic traumatic brain injury, on a few types of dementia. And you're going to ask, why is that related? Well, because they're all essentially problems where, among other things, of blood flow, we'll say. Certain types of dementia, certain of these things. With these chronic diseases that we know are chronic and degenerative, the issue is, while you're in hyperbarics, will help to build you back up a little bit, but then the normal course of the disease is downward. So we haven't yet found a good lasting benefit. And I don't think anyone wants to come daily, indefinitely. Certainly some people are trying out on their own when they can afford it. I'm sure you might have heard of some of these, for other indications again, basketball stars and things like that, certain pop singers, who have purchased their own hyperbaric chambers and try to use it for various things. There's just not enough data on it. There might be other effects, though, that we'll find out over time. But right now, kind of the jury's out, but it's a very interesting point. Yeah.
When you showed the slide of when it was like 5 in the middle of the unhealthy wound, and then after the hyperbaric it came out to the 50, how many treatments did that need, and how long are the treatments?
Good question. So normally, it's 20, after 20 treatments, there's actually Robert Marks' data that showed us, because he did these serial biopsies, which, lesson for doing it, and his patients for putting up with it, but he did these serial biopsies and showed that, yes, it takes about 20 to get to a plateau of 80–85% of normal vasculature. Just like the scar tissue with everything else, you really won't get much more than that. Certain indications, we do more treatments than that. Normally we do anywhere from 30 to 60 for various treatments. It's often for other reasons as well. A lot of them clinical, just showing that 20 is okay, but it's the bare minimum. Some people are worse than others and need a little bit more. And in certain indications we've just found, if you extend it out, you get X amount more benefit. But it's certainly, at that point, we would have a good conversation as far as, are you happy with where you're at? Is this a good place to stop, for whatever the indication is? If you have blood in the urine, for example, is your pain gone? Are you okay with a little bit of spotting now and then? If so, maybe you don't need to come back for the extra month and a half of treatments, and then you're good to go.
Are those daily and how long?
They're daily. Most of them, for almost every indication, is about hour and a half a day. Ballpark. So yeah, and it's Monday to Friday, because we do like to give everyone a break, including the patients, also ourselves. But you do need that little bit of a break, even for medical reasons. You don't want to have too much oxygen. I didn't know that, but there's a way to get too much. There's another question back there. Yes?
I was wondering about the silver, and when
Yes.
we first talked about it, I thought, well, do you expect that there's going to be some type of silver embedded in Band-Aids sometime soon? Do I have a great idea or what? Do you think we should market it?
Well, we're all witnesses. It was your idea, so it's there for you to market for sure. And develop. I think Band-Aids with silver. I don't know why I've never seen that. It's an idea.
We can follow
Expensive
up on
box
it.
of Band-Aids.
It would be an expensive box of Band-Aids. That's probably what it comes down to. Yeah.
But then you also said that silver could have some side effects as well, so I wondered if that's right.
For the most part, most people don't react to silver, which is why so much jewelry is made out of silver and gold and things like that. Silver being usually the cheapest of those rare metals. And actually there are a few, I've recently seen a few gold dressings, and I just think to myself, wow, how luxurious is that you have a gold. I don't know how it's better than silver, there's no research out on that. But certainly, what you can have though, if you have too much silver, is some people can develop a little bit of sensitivity to it, as you would to any kind of silver jewelry. A lot of people have sensitivity, say, to nickel jewelry and other things like that, or brass or things like that. So those are a little bit more common, but as you, for some reason, as you get into more expensive metals, you tend to have less of a reaction to it. It just happens. Yeah, exactly. All good. Thank you. Yeah.
I remember growing up, whenever I had a cut or a wound, even something pretty significant, I would be thrown in the family swimming pool, because my grandmother believed that the chlorine would heal. Is there, and it seemed to, I'll be honest.
Okay.
Is there anything to that?
Well, I will say that young people who are otherwise healthy tend to heal very well no matter what you do. I'm sure we've all come back with mix of mud and blood and things on our knees and whatnot, and they heal. They don't get infected. Most kids don't walk around with amputations from that.
Fair enough.
I wouldn't recommend it to anyone. I think of all the places where you could possibly stick a wound, a well-coordinated swimming pool is probably one of your better things to do, but I still really don't recommend it to anyone because you don't know how much chlorine is in there. It's not going to kill everything, and we know that. Certainly there are certain things that one thing that I didn't talk about is when we think a wound has a little too much bioburden on it, and we're giving antibiotics, we're doing everything else we can, we're doing our debridements, but there's still too much. A couple things we can do, we can wash it out with increasingly harsh things. So normally I ask people just wash it out with soap and water, and if the water is such that you can drink it, then it's fine for washing it, because it's not going to have bacteria, it's not going to have anything too bad. That's fine. But beyond that, you can use a mild vinegar solution to wash it out. That'll help a little bit. You can use a mild bleach solution that we show people how to make, call that Dakin's. That will help. And there's other antiseptic things that you can do. You can also instill those into the wound and leave them there in certain cases if it's really, really, really bad. Oftentimes on inpatient, that'll be the case. So there's a range of things. The swimming pool doesn't fit into it. It's a good thought. But the chlorine, yeah, for sure. And chlorine is a part of bleach. Yeah, exactly. So it's a good thought. Yeah.
How about salt water?
Salt water is actually specific bacteria that do live in salt water more often than in fresh water. So every bacteria has its preference for where it likes to live. And I don't know if anyone fishes out in the deep sea or anything like that, but I'm sure you can attest to the fact that there are plenty of infected cuts you can get from equipment out on the ocean. Many of them very nasty, or bites from, or even slashes, not bites. Bites are their own problem, but slashes from sea creatures and things like that. So, salt water in itself, not going to be generally clean enough on its own for wounds. Great.
Thank
Thanks
you.
again.
Thank
you.
Wonderful, absolutely wonderful. Thank you again.